The Sage Women podcast shares real conversations with women and health professionals, and it's for anyone navigating the ups and downs of midlife.
Hi, it's Melanie here on the Sage Women podcast. I'm really excited to introduce Stacey Roberts, a holistic registered nurse, physiotherapist, and functional medicine specialist with over 30 years of experience helping people to heal chronic pain naturally. She's the founder of New You Health and Wellness and the author of the Pain-Free Formula and the host of the Pain-Free Formula podcast. And we will have links to those in the show notes. Stacey, thank you for being here today.
Oh, thank you so much for having me, Melanie.
My pleasure. I just want to give a quick summary for those who are wondering what this episode is about. We'll be talking about chronic pain, obviously, which is your specialty area, and also alternatives to conventional approaches to managing pain and ways that women can be empowered to address, eliminate, or manage pain. Often that pops up in midlife. So, Stacey, I would like to start by asking you what got you interested in pain as a topic, as an area of work?
Sure. Absolutely. As a physio of now, 36 years seems way too long for that to be possible, but I've helped people with pain for decades. But lately, especially going through midlife, what I found over time, well, even back when I was beginning physio, I would always wonder why, if patients are doing everything that they're supposed to be doing, and following through, why some of them didn't get better. So it was always a question that I had, even in the early years of being a physio. And then as I, went through my own transition in life, I observed different patients along the way. I started to look into first how stress affects pain and how pain affects the brain. That was kind of my first interest to understanding different ways that the brain processes pain. And then it started to move into hormones because I was going into my own perimenopause and menopausal, and then also gut health because I was having some joint pain myself that I couldn't resolve as a physio. And when I went into nursing to expand my scope of practice to go into functional medicine, did a lot of functional medicine in Australia when I had a clinic there. I just started finding that there are these pieces of the puzzle that kind of all fit together nicely for those who the straightforward exercise and biomechanics and hands-on therapy really didn't provide them the relief that I would have thought. So my own injury in 2021 really was a catalyst for me writing this book. When I was at a wedding, and in the Midwest in the US, we have a tradition at weddings of doing a dance called the polka, where you kind of dance around.
Oh, yeah.
Yep, you're familiar?
I know that one, yeah.
Yep. And when I was doing the polka, my knee just popped. I was with my 21-year-old son, and it popped, and I had searing pain in my knee, and I kind of had to drag myself off the dance floor, and my knee doubled in size right away. I couldn't put any weight on it. It was really like weddings there should be warning signs at weddings that if you're over 50, that it can be dangerous. So the beer barrel polka basically took me out of that wedding, and I used a thing called soft wave therapy on my knee the next day. So I was able to gradually walk on it, but I was really curious of what that pop was. And so I went to an orthopedic doctor to figure it out. And I felt like I was just completely dismissed. They looked at the x-ray and said, "Oh, you need a knee replacement." I'm like, "What? What are you talking about?" I didn't have any pain in my knee before that. But what that did do, I had kind of a light bulb moment at that moment. I saw in the x-ray I had significant arthritis, but I'd never had pain prior to that one incident. And years passed, probably 20, 25 or 30 years before that, I had surgery on that knee. But, who would have thought that, that far later I would have a problem. But I thought, why would surgery be the first line? Why aren't you offering other options? And the only other option they could offer me was cortisone injection. And as a physio, I know that can actually degrade the joint. So when she asked me why I wouldn't want the cortisone injection, I was really trying to be a patient, not being a provider, but she asked. So I said, well, the research shows that, with cortisone, you're degrading the joint more, you're degenerating it more over time. And I pointed at my x-ray. I'm like, why would I want to do that to the knee that's already compromised? And she said, "Oh, you'd have to have 100 of those cortisone injections in order for that to happen." And that just made me so angry because that's not true. And I thought to myself, how many people are hearing that in the doctor's office, getting the wrong information? Not that I'm against surgery or injections, but I would want my patients and myself to have the correct information so that I can make that choice or they can make that choice without without not knowing the consequences, right? That was my biggest concern. So that's why I said, okay, I'm just going to write this book. So that's how the pain-free formula is born.
Thank you, Stacey, for writing that book, because as you were talking about your story, I immediately had a list of people popping into my head who've had different sorts of injuries, shoulder, knee, and they've been told, oh, well, you can have cortisone and you can have this and we can't do anything for you. So obviously there's a knowledge gap here that needs to be filled. And so your work sounds like it's really doing that.
Thank you. Yeah, I hope so.
Yeah. And I suppose you talked about wanting to understand the link between stress and pain and hormones and pain. Can we start there? Can we talk about the link between stress and pain?
Absolutely. So cortisol is our stress hormone, and it gets a bad rap. A lot of people talk about it as something bad, where really when it's at its nice level, its optimal level, it's an anti-inflammatory molecule in our body. So it's only when we're under significant stress for a period of time and that cortisol rises, becomes more catabolic more often, which means that it's breaking down the body and we don't have as much kind of building this up, the body back up, that it can be a real issue with inflammation and then contributing for some people to pain. Other people, it's anxiety, some skin issues, some fatigue. It affects everyone differently.
Yeah.
Same is true in later life. If cortisol is too low, we lose that anti-inflammatory capability of it. So it then either high or low cortisol can set us up for feeling more pain due to inflammation. So that's only one hormone that can impact, and that all can impact the brain as well too. When someone experiences chronic pain, their brain actually changes. Their brain starts to really be in protective mode and become more hypersensitive. So pain that would only be, let's say, I don't know, level 2 out of 10 before, if you had chronic pain for a while, you can become more hypersensitive, and that pain might be like a 5 or 6 or 7. Wow. So the brain is really trying to do its job in protecting us from getting hurt further, but over time it becomes detrimental to us because we stop moving. We are fearful of doing things that we want to do. So we get into this really perfect storm of avoidance, and then movement is medicine. So then it starts to spiral into more pain and more difficulties.
So interesting. And then it gets me thinking about, well, what kind of pain are we talking about here? Are we talking about, you mentioned your example of the knee going pop. I've got a twinge in my lower back at the moment. I know people that have other sorts of pain. Are we talking about arthritic pain or pulled muscles or all sorts of pain? What's the scope of pain?
Sure. It's really any type of pain, but a couple things that people need to also understand is there's discomfort that is okay to work through. Like if you have sore muscles and you're just started lifting weights, and sometimes you have to work through that. But when it's pain that's debilitating, when it's pain that's achy or sharp or burning, or really could be from arthritis, a pulled muscle, really anything could be the source. And then we're experiencing that, and it doesn't go away because our body has a nice, wonderful, miraculous healing process on its own. If I scratch my hand, it gets red and puffy. If I stop scratching it, so I take the trigger away, that red and puffy part, the pro-inflammatory phase of healing, moves into an anti-inflammatory phase. So I look back at that scratch 2 or 3 days later, and I can still see it, but it's no longer red and puffy. That's the anti-inflammatory phase. That allows us to then the tissue to heal. So what happens with people who have pain and it's not going away is something's interrupting that process from going to pro-inflammatory, anti-inflammatory healing. So that could be that it's still being triggered. If I keep scratching that scratch, it's not going to heal. So the person may be moving in such a way that it's continuing irritating something that's been injured in the past. But also, from a standpoint of a trigger, we definitely want to remove those. But over time, then we look at how is that impacting our brain? How are our hormones impacting it? Because our other hormones, not just cortisol, but for women in particular, estrogen, progesterone, and men, testosterone, they also can be anti-inflammatory, right? So if they're too high or too low, that can cause problems as well too. So it's really all kinds of pain. And just if you have pain one day because you walked 8 miles and you're not used to doing that, but the next day you're a little sore, and then the next day after that you're fine, that's normal pain. That has resolved through the body's natural healing process. But when it's persistent and it pops up for no reason and it lingers and, hangs around, then we have to start wondering, what's the source here and how can we address it?
And you particularly talked about too high or too low hormone levels, and I'm thinking about midlife when estrogen starts to decline rapidly. Am I correct in what you've said, that that would mean you're potentially more likely to feel pain or more sensitive to pain?
Correct. And the inflammation has a better chance of increasing. So when our estrogen levels are in a good phase and optimal levels, it's some defense against inflammation. So think about your estrogen levels are decreasing, your potentially testosterone levels decreasing, then your progesterone level is decreasing all at the same time. And for a while there, they're jumping up and down, right? Because in perimenopause, it's more difficult to kind of track those hormones. So they give us a nice anti-inflammatory. So a lot of people will say to me, I'm eating the same way that I ate before. I'm doing the same things that I did before. And why is this happening now? Oh, it's because we're losing our defense mechanism, and some of the things and habits that we did before that may have been more pro-inflammatory, now we don't have that protection against that. So whether it's, midlife and now we enjoy a glass of wine every night after dinner, or now we, maybe go out to dinner more because the kids aren't around or we can afford to. So those types of things that we were able to get away with for a while, and especially if we're indulging in things that are more are not anti-inflammatory, more inflammatory, then we don't have the protection against it. So we all of a sudden start to feel those things more because the inflammation is not as regulated as it was before.
Gotcha. I don't know. I hear a few people around me have said, "Oh, I wake up the next morning after having a few drinks and my knees are sore or my elbows are
Exactly.
sore." Yeah.
Exactly. And some people don't necessarily notice that right away because they go to the doctor or they just think, oh, I'm just getting old, or, we have that excuse. But it's more about thinking, okay, why am I having this pain? Does it make sense? Okay. Oh, yeah, it's the alcohol consumption. Well, I'm going to curb that back, right? Maybe I'm going to optimize my gut health so that maybe I can have a little bit of alcohol, but just not as much as I used to. And that's the same for foods. Maybe, I can have some sugar, but just not as much as I used to. Or maybe you have food sensitivities that you have developed over time, because also as we age and with stress and with the different things that we do in lifestyle, that can affect our gut health. So our gut health starts to change. And if we're in pain and we're not exercising, that's also a detriment to our gut health as well too. So it can be this unfortunate spiral if we don't step back and go, okay, what are my triggers and what can I realistically do to eliminate them or at least significantly reduce it?
And I suppose some of these may not be obvious. They're kind of hidden root causes of chronic pain. So you've talked about hormones, you've talked about gut health, and then what you're eating and drinking, alcohol or certain foods. Is there anything else, and lack of exercise or perhaps too much or the wrong type? Is there anything else that's a hidden contributor to pain?
Well, the stress, right? The stress that we have that we talked about before, that would be the other big contributor. And there are some genetic predispositions that for some people, they might have some nutrient deficiencies that they don't realize that they have. Again, their gut health is changing. Maybe they're not absorbing things the best that they can. So where I usually first start is the biomechanics. So if I can see that the person's moving inefficiently, you don't have to move perfectly, but if you're moving inefficiently and triggering the area that is in pain, well, we correct that first. And if correcting that movement pattern doesn't significantly eliminate the pain in a short period of time, 3 to 4 to 5 or 6 weeks, then we start to look at what other things. And I usually want to go to diet. What are you eating? Because that's a major source of our energy, right? But also a major source of inflammation if we're not careful about what we're eating. We don't have to be perfect. The body can handle some assault from certain foods, but not an overwhelming amount where the body no longer can handle it. Or if the body's compromised from previous immune issues, or they have an autoimmune issue, or they might if they've developed diabetes, or have cardiovascular health, if it's already compromised and we don't adjust and we keep feeding that fire, if you will, then that creates a big problem as well.
So there's a couple of things I'm hearing. What we used to be able to get away with, we can't anymore. And also at midlife, we also see the emergence often of other conditions. They may be there already, but more and more women are starting to be diagnosed with autoimmune conditions and diabetes and things at midlife, which then further complicates that. I guess it's your body sending you signals that, hello,
Yes.
something you're doing isn't working.
Exactly. And that's what I say about pain too, is it's not, I wouldn't say bad. It feels bad, but it's a message, right? So instead of taking the batteries out of the smoke detector, right? Because the fire is still going to be there, even if we take the batteries out.
Yeah.
What we want to do is say, okay, I'm having this pain. Is there a reason for it? Like we talked about before, did I just go on a long hike that I don't normally do? Or is it just kind of popping up for no reason and then stepping back and going, okay, what did I have to eat? Like if I experience pain now, the first thing I do is think, what did I have to eat over the last 24 hours? If there's no clear reason, if I didn't fall or if I didn't work out or whatever. So I think we're so used to, instead of doing that, we're so used to just not thinking and grabbing a pill and then taking that pill to mask the pain because we want to get rid of it as fast as possible. So we can't be bothered, right, with it. So that's the unfortunate conditioning that we've had from companies that sell those types of medications. And now it's, we've often conditioned our children and, they're used to taking, a pill for a headache. And instead of like back in the day, if I had a headache, it would be drink some water, go have a banana, go outside and play, those types of things. So unfortunately, we've gotten away from that and have tried to cover up pain instead of going, okay, well, what potentially is going on here, and then helping to address it.
I guess if you're not addressing the root causes, if you're not making some of those lifestyle changes, then it's quietly chipping away at what's going on in your body. It's
exactly
the pain can be sorted out with a medication in the moment, but the longer term damage is still occurring in a way.
Right. And even some of those medications can make you more sensitive to pain. So long-term use of NSAIDs or pain medications have been shown to, again, create that hypersensitivity to pain. So you think you're taking something to take the pain away, but you're actually prolonging it and increasing it over the long term, as well as not just prolonging and increasing it, but the healing process slows when we take some of those medications, especially NSAIDs. And we know that certain things aren't great for the liver and the kidneys, you're taking them long term. So we kind of forget that, right? Because we are looking for that to feel better as quickly as possible instead of listening to our body.
So I guess you've kind of talked about this already, but you've got the pain-free formula. How is that different from the traditional way that people manage pain?
Yeah, I think really the pain-free formula just lays out a plan for if you have an injury or if you have pain, and let's say you're an active person, you can't figure out, you didn't really feel like you tweaked anything, but something is starting to hurt. Doing the things in the pain-free formula that I first talk about is looking at your biomechanics, looking at how you're moving, right? But unfortunately, what happens, and many times if you go to the doctor or if you watch any sort of television that has any type of commercials, the first thing we do instead of getting information about how we can move better or strengthen or have more flexibility is we do the quick fix, right? So what I do in my book is I try to show how conventional medicine deals with pain typically. And then if that's not working for you or that's not a road you want to go down, what are the alternatives? Because it's not just medication, it's not just surgery. And I'm not against those things, but I want to make sure that people understand they have options outside of those things that may be more empowering for them. Maybe it will help them get to know their body better, and maybe will help them be healthier in the long run.
I love that. I see so many women, particularly, that are doing a lot of things. They have a lot of responsibilities and they've lost that connection with their bodies. They're on the treadmill of life, working, looking after kids, managing aging parents, all of the things that happen in midlife, and not really paying attention to those signals. So I love what you're talking about. It's a foundational part is just noticing and paying attention. And then I guess there's a point at which surgery or drugs or injections might be necessary. How would you work that out? How do you assess?
Sure.
that?
So, for example, I have a patient right now who I've been seeing her for 3 times. She gets better, but then not really where she should be. Each time you come to see me, when I do the soft wave therapy, my manual therapy, my exercises, we assess your biomechanics. Every time you see me, you should be getting better for longer. So if I saw you the first day and it was a few hours, then the next time I see you, it should be double or triple that, and then the next time should be longer than that. If that's not happening, then we've got to step back and reassess. This particular person, I believe she has some sort of issue in her knee with her meniscus. So based on the special tests that I've done, based on all those things, on the assessment, at this point in time, I'll be referring her, if she's not at least making that big jump and getting better, but next time I see her, I'll be referring her back to the orthopedic for an MRI to really look and see, is there some structural issue that's really here that I couldn't do anything with in my clinic. That's the perfect person that looks to see, okay, what is surgery the next thing? Sure, you could do an injection as well, but then just be educated that there are other injections besides cortisone that can help, like hyaluronic acid injections, PRP injections. So there's a lot of different options that people have today than 10 or 15 years ago. But often the only one here, at least in America, in the US, the one that's often suggested is cortisone because it's cheap and insurance pays for it. But it doesn't build up the joint. We know that. So other injections do build up the joint. So there's educating yourself about that process, really. So it really, you want to be with somebody who understands, when to say, you know what, this doesn't make sense, and this is more of a structural issue, and let's get another pair of eyes on it to take a look at it, get some more testing done. But then there's the other person that I had today who she was getting better than 3 visits, was doing great, and then all of a sudden she had this big flare, right? And it was right after Easter Sunday when she was eating very differently than she typically would be, and she's kind of scratching her head, and I gently had to go, okay, so let's go through what you had that day, and then let's talk about where this pain may be coming from. So then it kind of clicked, right? Because we're not raised to think that the foods that we eat are going to cause pain in our muscles and joints. We're just not raised that way at all. So in talking to her, she's like, you're right. I think that happened at Christmas when I ate the same foods. And I think that happened when I went to my friend's house and we had this. So it's being open to look for those connections as well. And then if somebody's in midlife or postmenopausal or right in menopause, then we potentially look at hormones as a potential cause for the pain. So that's really, we want to look at it from a holistic approach. And like you so aptly talked about, looking for the root causes of the pain.
I guess there's a lot we can do as individuals to bit of detective work on our own. Was it I ate this food and I did this thing, or I didn't do that thing, and we can have that assessment. But I think I'm also hearing that it's important to talk to a practitioner who knows their stuff, who can talk to you about alternative treatments, and at that deeper level, particularly that we all have blind spots as individuals and we think we know ourselves, and then we don't realize that. Like, I had a conversation with someone recently who was talking about how something has been quite a big challenge for them, and I said, yes, and you've also had this and this happening in the background, and she said, oh yeah, your life stresses,
right?
We tend to discount those things because they're part of everyday life, but sometimes having that, or often having the other person that you talk to or listen to can see the things that you can't see and perhaps guide you towards the stepped approach.
Absolutely. And really looking at what everybody can do at home is look at what they're eating, what they're putting in their bodies, right? Maybe taking some supplements that are anti-inflammatory, drinking some tea that's anti-inflammatory. So we can all do that. But if that doesn't help, if that doesn't get you where you need to go, absolutely looking out for somebody that can help you with that objective point of view, because you're right. We all in today's society have developed this kind of high stress threshold, right? So we're used to all the stress all the time, and we just have to keep going, or else, what else are we going to do? So we ignore, like we talked about in the beginning, we ignore those little signs from ourselves, and then we don't take the steps because we're too busy. It's hard to make dinner. You got 3 kids running around, or kids are teenagers or they're not driving yet, and you got to cart them around all over the place. It's hard to put ourselves first and take a pause. But we really need to, especially at times when our body is talking to us, like when we're in pain.
Well said.
Mm-hmm.
Stacey, can we talk about pelvic pain?
Sure.
Because it's coming up a lot in conversation. I'm seeing a lot of it on LinkedIn and social media,
Mm-hmm.
and some of the work that we've done with partners like Wendo. There's a high prevalence of pelvic pain for women. What is it that we're misunderstanding or that we don't know about pelvic pain that we need to know?
That's a great question. I think one of the disconnects, and it's funny we're having this conversation today because I had two patients in the last 2 days who have low back pain. Nothing has really resolved it. They've had acupuncture, they've had massage therapy, they've had physio, they've, done functional medicine, they're on hormones, they're doing everything, and nothing's really working. So what we talk about is the connection of the pelvic floor muscle, which is basically kind of a hammock of muscles that are helping to support things in the pelvic region. We talked about how they are connected to the hips and that can impact the back and all that type of stuff. And one person we treated at their pelvic floor, and her back pain for the first time in X amount of years was relieved, not completely, but she finally, it started to move the needle. So what we don't understand is pelvic floor issues can manifest themselves in many different ways. Even, headaches or migraines, right? Because it changes the way that we walk, a structure, things like that. Most commonly, it'll be low back or the pelvic area or hips as well too. But it's really important to understand that we kind of forgot that there was even muscles there until probably, 10, 15 years ago when people were starting to study it. And now so many people know more about it. Like pain with intercourse. I did a study with the current modality that we have, Softwave, in regards to dyspareunia or pain with intercourse. And so many women are told, oh, it's just because you're getting older and, that happens as you age. It doesn't have to happen. Same with incontinence, leakage. That doesn't have to happen either. And that's supported in the research. So I think we just really don't understand the connection that the pelvic floor has with the rest of the body. We're just starting to figure out that, the knee bone is connected to the leg bone and all that is really true. And now you add in the pelvic floor, and that's foreign to most people. But I am so excited that it's in conversations now and people are talking about it and asking questions about it because it's so important for both men and women, actually.
Can you tell us a bit more about that? Men and women.
Sure.
What is it that we need to be paying attention to?
Sure. So there's two main things, and this is really bringing it down to a very simplified level. So it can be much more complicated than this, but simply the pelvic floor muscles can be what we call upregulated. Okay. So if somebody has an upregulated pelvic floor, that's been shown to be that those muscles they're not really necessarily tight. Upregulated is more from a nervous system kind of description, but imagine a muscle that just won't let go. Okay. And that muscle then can cause other pain. So for women, vulvodynia, dyspareunia, those types of things. For men, that can be penile pain, testicle pain, low back pain, all those types of things. And what we want to do is get that to down regulate that pelvic floor, right? So both, whether it's male or female, we want that to be able to down regulate and be able to support. So just like any muscle, we want it to be able to relax and, and be active. So we want that same thing in regards to our pelvic floor. And there's just so much disconnect. I mean, some people, like I kind of was joking before, but it's really true, is that people don't even realize they have any muscles down there in the pelvic floor. So they're mentally not connected to that part of their body. So that's a lot of work that we do. And God forbid, if men or women have had sexual abuse or trauma in the past, that can be, also very intimidating to even think about and focus in on that area as well too. So it really isn't specific to women, although women tend to talk about it more than men. But men have just a potential to have an issue with pelvic pain and pelvic floor issues. As women, we just tend to, women, we have childbirth, which, obviously goes right through that pelvic floor, right? So, and we have the transition of menopause. So things that we talk about in regards to that. But really, there's no reason that men can't do things to improve their pelvic floor as well too.
say that it's not just about Kegel exercises.
No.
And for some people, that might not be the right thing. Can you tell us about some of the options that, let's say, women going through menopause or women in midlife might want to think about?
Sure. Kegels is really important from a standpoint of strengthening that pelvic floor, right? Most people are studies done that most people who thought they were doing 76% of people who thought they were doing Kegels correctly weren't even contracting those muscles. So there's a lot to be said about really understanding even how to do it, right? It's not really complicated, but again, with just that connection with our brain and the area of the body. But imagine my bicep muscle was in constant, let's say, contraction, or I've referred to that term as upregulated. It just didn't want to let go, didn't want to release. And I tried to strengthen that by doing more flexion, bending my elbow more. That's really not going to, it's not going to work very well. My biceps is not going to be very happy. So just doing Kegels, if you have an upregulated pelvic floor, which you won't know unless you see a pelvic floor specialist that checks it out and can tell you that, is not the answer. And oftentimes can be detrimental, make the symptoms worse. At the very least, if you're not even doing the Kegels, it's not going to make any difference. So we want those muscles to be able to, what we call down-regulate, to be able to relax or contract and maintain a sort of tone to support the pelvic floor and the low back and everything else, without being too excessive or too little. So seeing somebody and just giving them Kegels without doing any internal examination or talking about any of that is kind of throwing a dart at the dartboard with blinders on, right? And just kind of going, okay, maybe this will do something. And those chairs that are out, I don't know in Australia if they have Emsella chairs, the chairs that you can sit on.
Them. Yeah.
Yep, to help contract the pelvic floor. Those have been shown in research to actually make things worse if the pelvic floor is upregulated. So they're not the right thing for everybody, but somebody who has maybe postpartum pain or weakness, things like that, or weakness or pain later in life, they may need that, and that might be beneficial. But to just put everybody on it or to teach everybody Kegels is really it leans towards being irresponsible, because if for some people it can actually make them worse.
So it's really being assessed to figure out what's going on to figure out the right answer.
Exactly. Yeah.
Yeah.
Very important. Some very good pelvic health floor physiotherapists in Australia for both men and women that I've heard speak. I wish I could remember their names right now, but lots of really good education over the last decade for pelvic floor therapists that can really do great assessments and do a holistic assessment to look at the whole body and not just the pelvic floor. So as physios, what we should be doing is, if you have knee pain, I should still look at the foot. I should still look at the hip. I should still look at how you're walking, all those types of things. So same with pelvic floor. I should still look at your posture. I should still look at how you're sitting. I should still look at, even what you're eating and drinking to see what might be, contributing. So really a holistic look. And like you said before, sometimes, going to see somebody that is going to help connect the dots for us, because we don't know what we don't know, right?
Exactly. And while we're talking about pelvic floor, it leads me to think about core strength, because I hear a lot of women saying, "Oh, I'm getting flabby around the middle," and not that it's all about core strength, but we've got all that series of muscles, that shield in the front, the abs, the transverse abdominis down low. How do they tie into all of this?
Well, it's all connected, right? So number one, from the muscle point of view, all the muscles are surrounded by fascia, and you have an anterior fascial line, posterior, lateral fascial line. So all those muscles are connected. And so fascia is one aspect of it. So if you, let's say, had endometriosis, a laparoscopy for endometriosis, where they kind of poke holes and take a look and try to clear out if there's endometriosis in that peritoneal cavity or around the uterus or whatever, that scar tissue that's there in that myofascia might at some point be pulling abnormally on other tissue in another area of the body that might be close to it or further away from it. So that is one of the connections that we have. But also all those, the pelvic floor muscles are connecting to the pelvis, the abdominal muscles are connecting to the pelvis. So it will change the way our posture is, how we're moving, all those types of things. So one or the other can put strain or pressure on one or the other and cause some imbalances. So we need to look at all of that. It's very common they'll do fascial work on somebody's abdomen if they have pelvic floor pain or pelvic pain that's coming from the pelvic floor, because we want to try to address all the facets around it.
I'm just thinking of a scenario where someone has some pelvic floor issues and may or may not know about them, and they're in the gym doing planks and 300 crunches, and
yeah,
what's that doing?
Yeah, it's like overworking that, Kegels, like doing too many Kegels, you could make the situation worse. We have athletes, female athletes, marathon runners or sprinters, or that have leakage while they're running, while the pelvic floor kind of just gives out. It just can't hold anymore, and just can't help to hold that. So, and those are 20-year-olds and 30-year-olds. So by holding those muscles too tight for too long, they're eventually got to say, I can't do this anymore, right? And then give way, and then try to stabilize again. So it's understanding how to teach ourselves to down regulate, which is engaging the parasympathetic nervous system, which is our rest and digest nervous system. Sympathetic nervous system is the one where we're under stress all the time, right? Or it's the fight or flight. If we live in that mode, that's where we talked about the hormones before, that cortisol can get too high, or eventually we become burned out and it's too low. So all that feeds into the pelvic floor as well too. And I was talking to a patient today about, it's really interesting. Studies will show that the pelvic floor, like our unconscious part of ourselves, will sense if it's healthy, can sense if there's some sort of danger coming up. Like it will contract before we even move to pick up the box, right? Because we're looking at the box and we're thinking about picking it up, and then the pelvic floor gets ready, right? Without us having to consciously think about it, even though those are voluntary muscles there. So there's really some massive benefits, right, to having that connection with the pelvic floor, and either strengthening it or down regulating it, or do what you need to maximize its function.
There's lots in there, and it makes me wonder, what are 2 or 3 signs in the body that indicate that you need to go and see somebody to get help before things get serious?
Regarding pelvic floor?
Yeah, pelvic floor as a starting point, I suppose.
Sure. So it's very similar to any type of other pain. If the pain's just not going away, again, if you have done everything that you're supposed to do, or let's say done something unusual. For example, I've had patients I mentioned hiking before. I've had patients who went on a hike and all of a sudden they start having vulvar pain. And nobody really related it back to the hike or their low back, where their low back was strained. So we had to actually treat their low back then, because there's nerves that come out of that area that innervate that vulva, the genital area. So we had to look at that. So if it's anything like what we talked about, even from other musculoskeletal issues, it's not going away. If you went on that hike and you tweak something and then in 2 days you're good, then you're probably okay. Now, maybe it's a sign for you to be like, okay, well, I should really work on my core strength and my flexibility, and not just go out and do an 8-mile hike without preparing myself to do it. But if it's not going away, then definitely look to seek help for sure. For muscle or joint pain anywhere in the body. We often, it's interesting. We think about pelvic floor as something separate from musculoskeletal, and it really is made up of the same thing: muscle, bone, ligaments, fascia, all the thing that's in everywhere else in the body. But somehow we separated that out into like that it might be separate, and it's definitely not. It's, everything's connected.
Anything that we notice is painful and not getting better and not going away.
Right. And
could
in
be a sign
midlife,
of something else.
Absolutely. And in midlife, it could be incontinence. Like I mentioned before, it's incontinence. People think, oh, I'm just getting older, that's supposed to happen. Absolutely not. I mean, that's shown in research that you don't have to have incontinence just because you're getting older. Painful intercourse. Many women are like, oh, it's just because, I have the vaginal dryness, and, that's all. And there's nothing I can do about that. There's heaps to be able to do in regards to, those types of things. So pain that's not getting better for sure, but also not, just dismissing things because of age, or going to a physician that's just going to dismiss things because of age, right? That's a big thing where now we've got, information at our fingertips. We can figure things out if it is a problem where we should continue to seek help with, right? Versus just relying on one person saying, nah, that's just the way it is and there's nothing we can do about it.
I'm wondering what the best way for women to get help is. Do they need to see somebody in person? I'm thinking of, I live in a regional area and there are a lot of women living in regional and remote areas. How much of this sort of consultation can be done on telehealth?
Some of it absolutely can be, and there's some good research showing how it can be very effective. Some of it is more challenging, but doesn't mean it can't happen. There's ways that you can teach yourself to do assessments. Probably not going to be as good as a assessment by a pelvic health therapist, but certainly there's ways that person can coach you over telehealth and talk to you about what you can do to assess certain things and ask you questions to kind of see what structures might be involved, or have you stand up and do some movement so that they can watch you move while you're on telehealth and then be like, okay, that's interesting. So I'm going to have you do this next. And how does that feel? That type of thing. My preference, of course, is to have somebody in clinic so I can put my hands on them and be like, okay, this is what then I want you to do and what we can do after we assess. But absolutely, telehealth with a talented therapist can be really beneficial in regards to pelvic health, or really any musculoskeletal issue as well. Sometimes you do need that modality or that next kind of phase to help accelerate the healing process. But absolutely, telehealth is a great option, especially to get started.
To know for a lot of women listening, I think. Yeah, thank you, Stacey.
Sure, absolutely.
One last question before we wrap up. What are a couple of things that women listening to this could start doing today to better support pain-free movement and long-term well-being?
Great question. Number one is what we talked about and alluded to at the beginning, is start listening, right? Start to pause, even if it's a 5-second pause. Start to pause and listen to your body. That's the number one thing that you can do, because as you do that, you support that relationship with your body. So then you can figure out, hopefully sooner rather than later, if you do need help, right? Or if this is an issue that you can manage on your own with just changing your eating plan, things like that. The other thing is looking at your eating plan. That's the number one thing that we will talk about and say, what am I doing that I could probably do better? Am I eating an anti-inflammatory eating plan? And nobody has to be perfect, but really that 80-20, 90-10 rule to really look at that. And when we're dealing with pain, we don't often think of what we're putting in our body that could exacerbate it. But those are the two things that I would have people do right away. If everybody came into me with a food diary and said, hey, I noticed this pattern when I was, doing this, and this is how I felt after I ate this, it would go a lot faster, because I'd be like, okay, let's build off of that. Let's find something else that you can do that's not irritating you. So if everybody did that, they would be way ahead of the game and get better much faster when they see somebody.
Great advice, Stacey. Thank you so much. I could ask you a million questions. We could be here all day. So
Right.
Interesting. And it's helped me really join a lot of dots in things that I've experienced or that I've seen in other people, because you see what's on the surface, and then there's 2 or 3 things deeper that you might not think about. Just the interconnectedness of things, I think, as you've said, that we may not naturally reflect on, but I know lots of women now that I'm thinking everyone should go and see somebody who specialises in pelvic floor health, because you don't know what you don't know, and there might be things happening that you don't relate to that. So that's a really important takeaway for me, and I hope people listening to this have had some other sorts of takeaways too. This has been a great session, Stacey.
Thank you so much for having me. I've really enjoyed the conversation.
Me too. And I'm going to put a link to your book and your connection points in the show notes for people who are interested in learning more about your work. It's really refreshing to hear someone talking about a holistic approach, not just, okay, drive through, get the medication, drive out, or have the surgery, or have the injection. It's clear that there are a lot of other options we don't know about and that we need to be considering.
Absolutely. Absolutely.